Well, with that, good afternoon, everyone. Thank you, Dr. Kaplan, for being here. And thank you, everyone who's joined. Today, I'm very excited because we are going to actually hear from a dynamic team here in Florida. I want to start, though, by going through our agenda for today. And if you could advance the slide for me, Shane. I know it's been a while since we talked, but there's been a lot of things that have happened over these past, 2 weeks. So I want to just start with the COVID-19 state of the state and then review some headlines and updates. And then we're going to hear from our Optum ISNP team in Florida. And we will have time for questions and answers and discussion later. So I thank you all. If we could go to the first slide, Shane. So this is just an overview of where we're at. This was taken from the update that was provided on Johns Hopkins Coronavirus Resource Center at 8:32 this a.m. And if you're not speaking, I do ask you to put yourself on mute. We know that since the last time we talked, we know that we've seen even more cases, unfortunately over 82,000 deaths in this country. When we look at what's happening in Florida, you go to the next slide for me, we're actually seeing more total cases in Florida, over 42,000 at this moment in time. And this was updated at 11 a.m. this morning, with the hottest spots in Florida still being that South Florida area, the Tri-County of Palm Beach, Broward, and Miami-Dade. What that means is that when we're looking at everything, and if you go to the next slide for me, what we've seen is that there's been a blunting of that curve, not a little bit of a plateau when we're looking at what the United States is facing for hospital resource use. But where the most alarming part of all of this is that we're still seeing the projections for deaths that we're going to see in the United States is actually shooting up. And that is really due in part to where we're at as far as reopening states. So this next slide is just a bit of a map for me. If you go, yeah, and it's from, I pulled this from the New York Times. They had a great article about reopening of the states. And so this just shows where we're at. And this was updated on yesterday evening, May 12th. It shows all the states that are in either partial reopening or planning to reopen soon. And you can see Florida is in that darker shade of blue. Some states are still, holding steady with the shutdown and restrictions, those being Washington, California, Illinois, and New York. Just to point out where we've seen a lot of cases. So as we are getting to the point where we're seeing states reopening, businesses reopening, there's been a lot of questions and concerns. And what Dr. James and I were actually talking about earlier, Dr. Fauci's time on the Hill yesterday, what was the one of the things that he mentioned, you go to the next slide, was the way the amount of deaths that we are now being projected to see. So a few weeks ago, this line was a little bit flatter. We are now anticipating that, there are going to be many more deaths. And this is in part due to some of the rollbacks, the reopening conversations, the lifting of restrictions for social distancing. So this is a projection, and it's from the COVID-19 projections. And it's just something that we need to think about, because we know that where the trend for these deaths are going to hit us the hardest is in our space, in the post-acute long-term care space. So just moving on through some more updates, I want to make sure, it leaves time, the majority of time, for our speakers today. So if you go to the next slide for me, just since the last time we talked, the FDA's revised its policy on the antibody test, prioritizing access and accuracy. So there are some new updates in their guidance that they gave back on March 16th. There is now some more up-to-date guidance around using serology tests, looking at how we're doing, and they're not recommending it for an acutely sick person to have. They're still stating that the antigen test is better, but I thought this was interesting as we're seeing more of these antibody tests come out from different manufacturers. If we go to the next slide, there has been some update that came out actually a few days after our last conversation around remdesivir. What we've seen is that the FDA issued emergency authorization of remdesivir 2 days after the National Institute of Health clinical trial showed promising results. And this has been over the news over the past 2 weeks. There are still studies doing it. We're always being mindful of the side effect profile that this drug and other drugs have. So, you know, it is something to be aware of, but what they found is that there was a 31% improvement rate in those individuals who received remdesivir. So there is some promising findings out of that. If you go to our next slide, I just want to point out that as we anticipated, I think way back in March, the hotbeds, the places where we were going to see a lot of cases and challenges is in the nursing home space. And this is an article that came out on Monday about the New Jersey investigating their one of their state veteran nursing homes. I believe they had 72 cases. You know, that same day I was sent an alert about one of the facilities at Broward County that had 25 cases going out. And it's just, it makes you always realize that, you know, as we were challenges and the cases of COVID-19. The next article that I just want to highlight is just what Florida is doing. You know, there are some things that Dr. James and Renee Lebon are going to talk about where we're seeing some things happening in the state of Florida around new testing mandates to identify nursing home residents who have COVID-19 and stop the spread. There's still so much for us to do. And like I said, I don't want to be the main person talking today because we have a great presentation coming forth from this Optum team. If you go to the next slide for me. So I want to introduce the Optum ISNP Florida team who's going to speak. You know, Optum's my old stomping grounds, and I'm just really impressed with everything that they've been doing. I will let them each introduce themselves. You can either come off mute and introduce yourselves now, or we can do it throughout the presentation, whichever you feel is most appropriate. Dr. James.
We can just introduce ourselves as we start talking, if that's okay with the rest of the team.
Yep.
Thanks.
So I turn it over to you. Thank you.
Sure, thank you. Well, I want to start, I won't take up much time because I want to get to the rest of the team, but I did want to start by saying that I'm a physician, I'm a scientist, I do have a public health degree. I'm not an economist, I'm not a forecaster. I'm just going to present the facts and you all can make your own decisions. And if you watched any television yesterday, you know why I said that. Just to break the ice. I am asked to give a commercial disclosure on behalf of those on the call with us. We are full-time employees of United Health Group in the Optum division. We definitely want people to know that. That is our job. We're not making this commercial. You'll hear some references to the program that we administrate, but we're mainly going to focus on facts and what we do every day, or what the practitioners do every day in the field that the managers oversee. You can go to the next slide, please. Before I get into that too, just really a quick overview of the program itself I was asked to give. The program that we administrate is the United Healthcare Nursing Home Plan. This program was actually started 25 years ago by two nurse practitioners who definitely saw a gap in care in Minnesota. It started as a Medicare demonstration project, was brought under the United Healthcare umbrella as Evercare, and then about 7 or 8 years ago moved under the Optum umbrella, but always still fully under United Health Group. The program provides preventive management for the most medically complex members in skilled nursing facilities. And what makes the model unique is it breaks the cycle of just one-on-one care by creating personalized care plans. It elevates the care quality and reduces avoidable trips to hospital at the same time. So just a really quick overview, and some others on the team might have a little bit more to add to that, but it's more personalized touch with having a practitioner in the building that collaborates with the physician as an extra set of eyes and ears. The other quick thing is that we are currently live in 22 counties, and with as many as 6 more that we're going to go live in the rest of this year. On the East Coast, we run from Jacksonville, Duval County down to Miami-Dade. And on the West Coast, we run from Hernando County down to Lee, and then we're much in the central part of the state with Polk, Orange, and Osceola, Seminole counties as well. So on the statistics, the brief overview for me is it really started to hit home a couple of weeks ago when the nation passed 50,000 deaths and nursing home residents passed 10,000 deaths at the same time, basically, in the same week, basically. So at that time, we were 20% of the deaths. And if that didn't make people sit up and take notice when groups like AMDA actually notified people that, well, that's true, but nursing home residents only represent about 0.5% of the population. So that was about a 40 times rate of death in the nursing home compared to the general population. Going forward now, this is just from earlier this week. The numbers will be a little off what you're seeing because we did put these slides together a couple days ago, but we've gone from 20% up to 35%. One of the reasons we think it's going up is there's finally a call from the nation and from the government to actually report nursing home deaths. And that actually was official as of last Friday, but what I'm reading is that the White House is telling us we won't have a report until at least June 1st. So some of this data we're getting county by county, and I made it as accurate as I possibly could. In the state of Florida, we're close to the national average where about 33% of the deaths are from the nursing home. I did throw in Colorado to show you there's quite variability in the country. It's as high as 54% of the deaths in Colorado. In Pinellas County, because that's where I am, a significant increase. One of the reasons is last week we had the #1 home for deaths from COVID, and we're still losing residents from that home every day because a lot of them are in the hospital and they're passing away. And on the bottom there, I did note the population of the country, of the nursing homes compared to the rest of the country. And that's why it's somewhere between 50 and 100 times the rate, depending on what county and what state you are, for the rest of the population that gets COVID. If I can go to the next slide. And this just a brief overview of our program. I won't go into this in detail. This is as of a few days ago. I looked at the numbers this morning. They're already higher. And I don't want to steal any of Renee's thunder. She may be talking about this as well. I'm going to go to one last slide, which is the hospitalization rate really kind of jumped up and smacked me in the face. When you look at the low of 18 to 29-year-olds of being 11.8 per 100,000, the rate goes up anywhere from 1.5 to 2 times for each of the next several age ranges up to the 30 to 39, 40 to 49, and then all the way up to the 85, which gives you from that lower younger adult age up to the 85 plus a 25-fold increase in the rate of hospitalizations just based on age per 100,000. And I've referenced that slide as well. I realized that I did not put the references on the slide, but when the final slide deck is done, that Dr. Sanders will send out, it'll have references for everything that I've presented. And with that, I want to kick it over to Renee, our Director of Clinical Operations and our lead clinician.
Thank you, Dr. James, and thank you, Dr. Sanders, for inviting us and welcoming your forever family, I'll call it, because I won't say former. So thank you, everybody, for having me. My name is Renee Lebon. I'm the Director of Clinical Operations for the state of Florida. I come from the long-term care arena as a nursing home administrator, so I definitely can see both sides of how this virus is impacting all of the business. On the Optum side, we're faced with this challenge of how can we live our cultural values, how can we best support our members, our facilities, and our clinicians by maintaining safety. So one of the first things that we really had to stand up was fit testing. We had to fit test about 120 clinicians. It was definitely a challenge. We had one hood initially and eventually got many more. So that was the first step. We traveled that hood around the state like a rally, passing it from one manager to another, and we tested all of our clinicians to make sure they had the proper PPE to go in and see our members. The next thing we did was really evaluate how we were gonna see the members safely and ensure that we didn't become the vector of this disease. So we sat down as a team and strategized around how many buildings our clinicians were going into. There is some areas of the state, a typical caseload for one of our practitioners is around 70 patients. So there are some areas in the state where they're in a single building, but there are several areas where they're in 2 or 3 buildings. And we said to ourselves, how do we keep the virus contained or keep it out of the buildings to begin with? And so we decided that we were going to have our clinicians only go to 2 buildings and not on the same day. So they were seeing 1 building a day, rounding on all of the patients, seeing their acuities, talking to the staff, supporting the staff, giving them education on what we were getting from our medical director crew and our education team to make sure that we were passing that information on what to look out for, how to treat. A lot of the groundbreaking signs and symptoms and manifestations we wanted to share with our partners. So clinicians were going into 1 building a day, the next building on the next day, and trying to alternate as best we can. And then we stood up and said, well, if there's an acuity on a day we're not there, how are we going to still provide our level of care to our patients? So at that point, we started to stand up some telemedicine initiatives. We issued some iPads or leveraged existing iPads in buildings and tried to do our best to utilize the leeway that we had with telemedicine to still see our members. A lot of the docs that we work with were like, I'm comfortable treating in place as long as somebody sees the patient. And so this was our way of still seeing the patient every day if needed, but from a telemedicine platform. Next thing that we did was try to get PPE to our frontline staff aside from the N95s. Everybody had a supply at that point of N95s, but we weren't in the business of ordering PPE for our clinicians. We were usually using facility supply, and as we saw that supply dwindle, we really said to ourselves we had to supply our clinicians with what was needed. That's when I became really good friends with the UPS man in my neighborhood because all of the supplies came to my house. And I have 2 children and I leveraged a little bit of their help, and we repacked all of the supplies and sent them out to the 10 managers that we have working for us so that they could distribute it to their teams. At that point, we felt really good. We felt really safe. Our clinicians felt empowered, they felt protected, and they were happy to go out and see the members. I think at that point, we were able to leverage the FaceTime as well and help some of the family members see their loved ones that they hadn't seen. We have some really amazing stories of a lot of the extra work our clinicians did to live our relationships and our values of integrity. Then we started to see positives come through. So some buildings started to become positive, and here we had a clinician that was in a positive building and potentially in a negative building. So what we did is, as they became positive, we structured their assignments so that they would not go into a positive-negative combination. All of the clinicians were either in 2 positive facilities or 2 negative facilities. And if there was an instance where we could not accommodate that change, we would switch one of the facilities to telemedicine, depending on the acuity, the membership, the relationship, how, you know, the feedback we were getting from the facilities. At this point today, we're out of 30% of our facilities that have been closed to clinical. Either the medical director is seeing all the patients in those buildings, or they've closed out the whole medical team. Initially, we saw really specialists being closed out, but that has escalated depending on the outbreaks. The other thing that we're currently seeing is, and I know my team here will allude to, is the Department of Health and the National Guard testing. We've even had some hospitals come out and swab all facility or all members, residents in the facility, not just our members. So widespread testing of staff and residents. And, you know, as we get those results, that's where we're seeing those big numbers of facilities that have 90 patients and that have tested positive. And then the last thing that I really wanted to point out was just the spread, how we've seen it. You know, Dr. Sanders did allude to the Miami-Dade, Broward, Palm Beach being the hit, but we've recently seen it spread over. I have one of my managers here from Miami and the other one here from the Lee, Sarasota, Charlotte area. And currently we're seeing more uptick in Hillsborough and Pinellas as well, but it's definitely kind of hit all of our territories at this point. And with that, I will give it over to Bertha.
Well, I'm going to unmute myself. Thank you, Renee, and thank you so much for inviting us, Dr. Sanders, to be present in this call. And I am the clinical service manager at the ANP, nurse practitioner at Miami and Broward County, North Miami area and Broward County. I have 15 buildings under my care, 9 practitioners, about 680 patients, and from those we have about 65 members that have become positive for COVID, and all the buildings have been affected in a way or other, with the staff or patients being positive, and we have been able to do keep in place. As of now, we have 55 members in place in the buildings. And I want to go over what happened at the beginning that I saw in my area. In the beginning, there were facilities that had enough PPE, and they were supplying, like Renee said, but there were some other facilities that didn't have much PPE. There were other facilities that were using a couple of days the same mask as they were waiting for more supplies. We were able to obtain PPE from our senior management and start going to the facilities and seeing our patients. Some of the facilities were not testing for COVID in the beginning, and we saw an impact on the staff as they were fearful, as the facility was not testing at the beginning. Then we saw the National Guard and some hospitals, and also the Department of Health coming into the buildings as more cases started getting into, and more fear also about the spread of COVID. We saw facilities that closed early in the process of the pandemic, and some facilities that were still open. As of now, I have 2.5, I would say, buildings closed. 2.5 because they allow the practitioner to come once a week only to see the patients, but other 2 buildings that are not allowing the practitioner to come at all. So she has to do FaceTime or telephonic calls to the facility to keep up on the patients. The impact that I saw on the residents and the family was tremendous. Families were in a lot of despair. They could not come and see the patients. Due to decrease in number of staff in the facility, nor the phone was not answered all the time, so they could not communicate with the loved ones. So that created a sense of more stress and also despair from the family members. So we instituted Zoom or FaceTiming, and that was something that the practitioners started to try to mitigate that issue. Also, we have seen the depression and lack of appetite in our members as they were more isolated than ever within the facility, as they had to be inside of the rooms, not sharing commute areas in the facilities, and having to have lunch or dinner at the bedside instead of in the dining room with the other nursing home patients. And that had caused an increase in depressive episodes and weight loss that we are monitoring very closely. When we saw that despite efforts, the spread was in the buildings and more cases were coming, we, in partnership with the facility and the PCPs and the medical director in the buildings, came and said, what are we doing? What is the plan? In case that you have more patients that are positive, what is the plan? And as Renee mentioned, many doctors said, as long as the patients are okay, we can keep in place. If the patient develop respiratory issues, we had to transfer. And at that point, we were working with the families also to advance care practice and say, what is your goal for your loved one? What do you want to do? And that helped the family to decide what they wanted, and working with the PCP and the facility to decide what was the plan of care for those members. So we have facilities with 70 positive COVID patients or more, and we have other facilities with 20, 30 patients in place in designated WIN area. And the facility has gone through a lot, like they had a specific elevator created only for the COVID floor, not a specific staff dedicated to that area, and trying to do the best that they can on this situation. One of the reasons that the facility has been able to do that with us as a partner in a partnership is because the doctors have approved that if the patient is stable, they can stay in the facility. Now, if we are unable to advance care practices or the family decide that they wanted the loved one to go to the hospital, those patients have been sent. We had episodic that if the facility doesn't have a opportunity to have a designated isolation area, the patient has been sent out to the hospital. But it's, most of the time they are open to treat in place and keep the patient as long as the patient is in a stable condition. We have seen patients, many of them, even though they came back positive for COVID, they have no symptoms. We have seen after a week, they had developed pneumonia symptoms. And we have seen a few cases already that have come back negative for COVID in the facility without going to the hospital. So those are things that we have seen that make us believe that there is hope. We had cases that the family said, I don't want my mommy to go to the hospital. My mom is a DNI already. I want to go for hospice, and the patient was COVID positive, and the COVID test came back negative last week. And we were like, oh my Jesus, this is great. But we have lost some patients also. Many of them have passed in the hospital as they had been transferred from the beginning to the hospital. So those are my stories. I think there should be a way to manage in the future. I hope that things get better for the nursing home facilities and they can find better solutions for these poor members that are more than ever isolated in there, and the staff of the facility also that are going through a lot of different stages of stress. But overall, I think it's possible. And I will give it to Liz.
Hi, good afternoon. Are you able to hear me okay? Hello, my name is Liz VandeVelde. I am a nurse practitioner as well as a clinical service manager. And I am a clinical service manager on the west coast of Florida. My territory extends from southern Tampa area down to almost Naples. And that includes 4 different counties. I currently have 18 buildings. I have 12 of those buildings are COVID positive. 6 are currently negative that we know of. I have 56 confirmed COVID positive. And we are waiting results from the Department of Health this week on 4 other buildings that have been tested. So I expect those numbers to increase significantly over the next week. It's generally taking about 3 to 5 days to receive those results from the Department of Health. Of my membership, I have, well, in the beginning of March, my membership was around 590 members. Right now, as of this morning, I was at 552. Now, I attribute that to, of course, natural attrition. We have had some COVID deaths, and there's been a significantly decrease in the elective short-term surgeries, so there's not very many short-term admissions. My team does a combination of both the long-term and the short-term plan. I have several buildings that do both dual model. And it's interesting to hear Bertha's comments because I wrote down several of the same kind of things that I've seen in my buildings, Bertha. So I'd like to go over those with you as well. I found that there was about 5 phases in my buildings. The first phase was what I call denial. It was, almost being prideful that the COVID was not going to impact their building. There wasn't a lot of preparation or foresight that it's ever going to break our walls. And there was a little bit of lack of knowledge. And I think that's general for all of us. We didn't really know the monster that was evolving. The second phase was when an employee or a patient had the first positive screen, and suddenly there was a lot of angst and anger in the building. Who brought this in? Is the employee working at 2 different facilities? They started to do screenings at the door. The criteria was very minimal at that time, and then on almost a daily or every other day basis, the criteria of screening at the door seemed to increase. So there was more and more questions. So initially, one of my screenings at one of my facilities was only, have you been on a cruise ship in the last 14 days? Well, that evolved into, have you traveled out of the country in the last 14 days? Then it was, have you traveled out of Florida in the last 14 days? So you can see how the screening questionnaire really evolved. They were very reluctant, but they did start moving forward and doing the screening. Then the next phase that I saw was kind of the rationing of PPE. They didn't have enough of it. They were bargaining with other facilities trying to acquire more PPE. They were reusing PPE, and some facilities still are reusing PPE. None of the employees have been fit tested for the N95 masks, so there's always that concern. The criteria became stricter, not only letting people in the door, and they really shut out families at this point, but criteria for providers, nurse practitioners rounding in the buildings. Also, the nurses were told at this point, and the CNAs were told at this point, that they're only to work in one building, with the concern that they were spreading it amongst different buildings. Like Bertha said, this is about the point where the residents were told to stay in their rooms. There was no communal dining, all group activities are gone, and they were just starting with the idea of droplet isolation and precautions on residents who were known positives. because of all the restriction in not only the families coming to visit, the staff restrictions, and the patients being in their rooms more, the anxiety and depression really seemed to increase at the next phase. The staff, of course, had increasing concerns. There was a big knowledge deficit, fear of carrying it home to their families. There have been a lot more call-offs, and the staffing ratios have definitely increased. But at this phase as a positive, I think there was more PPE available, not only to providers, but also to the nursing staff, and they were being creative about making their own as well. And we started to implement some things like using FaceTime or the iPad to call families, and so they can actually lay eyes on their members. One of my mid-levels said, one of the reasons that people are being sent out when they're COVID positive and asymptomatic is just because the families they can't lay their eyes on them. So that was an important piece, is getting that iPad so that the families could actually see their loved ones. And I'm trying to do that pretty routinely with the patients that I'm seeing, and I know my team is as well. So that was a big, initially a big reason that people were getting transferred out. And then finally, we've come to the acceptance phase where, they're establishing COVID units. They're establishing a couple COVID units in some buildings, and then the isolation, the gowns are there. The mood seems to improve a little bit when they feel like they're protected and they have a little knowledge about what's going on in the building. They're doing vital signs every 4 hours. They're doing respiratory assessments every shift. The staff seems a little bit more cohesive and a little bit more of a team approach, like we're in this together. So that's been a really positive thing. And if you're astute enough on those 5 stages, you may have picked up that those equate to Kubler-Ross's stages of grieving. And it really does, that's really what came to mind when I was writing these out. But I wanted to focus a little bit, just a few minutes, on best practices, because I've seen some really phenomenal things in my buildings. Renee has said to us, many times over the last 2 months, this is a marathon, not a sprint. And we know that we're in this for the long haul. So like Bertha said, telehealth has been a big help for us. Even FaceTiming. I have one of my providers isn't able to go into the COVID unit in her building. So she may be in another section of the building, but if there's a member that's not doing well in the COVID unit, the nurse in the COVID unit is FaceTiming her while she's in her building and just having her lay her eyes on her. It's really important that they've put really trusted nurses and strongest clinicians in these COVID units. They're providing really great assessments for us, and they're noticing when there's a change of condition really quickly. Let's see, they've established these post-hospital units in addition to the COVID units within the building. So people who are coming back they're just starting to allow admissions back into many of my buildings. And those people who are coming back from the hospital are going to a post-hospital unit. On the unit, I have one building that's using oversized shirts, and they're soaking them in vinegar packets at the end of every shift, and then they're getting washed, which I thought was an interesting way to kind of go around not having enough gowns. So another thing that a facility is doing that I think is brilliant is, it's kind of one-way traffic. So people come in one way, and these are new admissions. They come in one way, and when that person is coming in, they call over the loudspeaker that there is a new patient coming, and that's the code to all the staff and everyone. They go into rooms. They make sure all the other residents are in the room. They bring this person in through the one-way entrance, and as soon as they cross the barrier into the COVID unit, the cleaning team comes and cleans down, and everybody stays out of that area for 20 minutes, which I thought was ingenious. The other thing is that people that are working on the COVID units are only staying on those units. They are not broaching the doorway into the regular facility. So they have like a back entrance and a back exit. They may not even clock in and clock out. They're just staying in their unit. They're separated from all the other staff and all the other residents. I've had a facility establish hand washing stations outside of the facility, which we can do in Florida. So that, you know, people know going in that this is the expectation. And there's also been, of course, staging areas for laundry, and especially for on the COVID unit. I have one COVID unit that has its own therapy department, or person, I should say, so that person is not doing therapy on anybody else. It's only for the COVID patients. Fluid rounds has been another really great idea because, you know, the one thing that we have seen are people falling more, they're weaker, and the falls are not only due to dehydration, but also them being isolated in rooms. So these are people that generally they try to congregate on a normal day in a day room or in the dining room or during group activities, and they're in their rooms by themselves. So fluid rounds and just, you know, eyeball rounds have been really important for us. The other thing that our team is really skilled at is just having those serious illness conversations with families and really preparing them for the what ifs. What if this COVID gets worse, or what if your mom has COVID, and what would you like for them? So that's been has been really important. Oh, I'm sorry. When I described fluid rounds, I was talking about the CNAs going around and filling glasses and actually watching the residents drink a full glass of water, and doing that every couple of hours, so that, because oftentimes they're not drinking on their own, or they can't literally, you know, pick up the glass and hold it themselves. So the fluid rounds has been a really, really great thing in our buildings. If people are going out to the ER, let's say they had a fall and we wanted to get a head CT, they come back to the building. If they've been in the ER, they definitely have to go back to isolation for 14 days. So they're not coming back into the general population. I think it's been really critical, our relationship with our primary care providers, that you know, we're keeping them updated on conditions, code status, patients declining, what the POA wishes are. One of my providers, I've created a list of all of our patients, all of their code status, and, you know, what the goals of care are, so that if he would happen to get called in the middle of the night, he would know not to just send them out. This is what the family wishes to do. So I think that he appreciated that. So I'm gonna give it back to Dr. Sanders, and you know, I guess we'll have questions. Thank you for having me.
Well, thank you, Liz. Thank you both, Liz and Bertha, and Renee and Dr. James. I actually was going to ask what fluid rounds were too, so I think that question already came up in the chat. You know, just as a comment, the 5 stages of facility grief needs to be written up and sent out to either JAMDA or someone, because that was a really unique perspective on what the facilities are going through. You know, I think you've given us already some keys to success for how to treat a place, you know, and some interesting discussion around the variability from Lee County and Miami-Dade and Broward County. I would ask, have you guys as a team seen any other places in Florida, or, you know, Dr. James, even on a national perspective, where there is significant variability? I believe in some of those statistics you showed us, we saw that from state to state there was different counts. So what is the key to either regulating that or improving on that variability from county to county, state to state?
Honestly, I'm not making a joke here. Some of it's been luck, but most of it has been good hard work. by the facilities that started early with taking it seriously in mitigation. That's not to say the ones that had the worst outcomes did not. I think they had some unfortunate either visitors or events that spread it. You're right, from a national perspective, we have seen it be devastating in our New York, New Jersey, especially New York City, where the density is so high. We have nursing homes that, whereas in Florida, most of our nursing homes are 1 story, maybe 2, rarely 3. There are some bigger, but in New York, it's not uncommon to have a 5 or 6 story nursing home with 700, 800, 900 patients. So the spread has been devastating there. In Connecticut and Mid-Atlantic as well, we have as many as 80 to 90% of our homes are COVID positive. I think my quick statistics showed that about 40% of ours are. I don't have the exact for Florida. Again, wasn't mandatory reporting until Friday. So we're starting to see it come in, and I did not want to report anything that was just hearsay. And then you have states where it's, everything is really spread out, especially it doesn't mean that the rural areas are not hit, they are. But where the population is less dense, it is occasionally less common, but not necessarily. This, it's been said before, I'm not the first person. This virus does not discriminate. Yes, it attacks the young. They don't, except for the kids that we're seeing with a possible Kawasaki-like syndrome that are being affected. The younger population, as you saw, like 11 per 100,000 hospitalizations are hit a little less, whereas our population is just being devastated by this. So it's quite a variety, and it is true, unfortunately, that African Americans and Hispanics are having a higher death rate, despite the fact that Caucasians actually are testing positive, because over time we know that unfortunately the minority populations have more chronic diseases. And hopefully one of the good things that will come of this is the uncovering of that, and that we do a better job at treating chronic illnesses early, and even in early adulthood, that we prevent more chronic diseases. That's one of the things I hope that comes out of this.
Diane, this is Joe Auslander. Could I
Yeah.
make a comment, a suggestion and a question?
Yes, please.
So my comment is I want to applaud this team. Unbelievably proactive, collaborative effort, and I think it's a model. My suggestion is, if you want to write this up as how an ISNP is dealing with this, do it and send it to the Journal of the American Geriatric Society. If you feel that's appropriate, I can get it I can get it online published very quickly if you direct it to my attention in a cover letter. And the question is, I may have missed it, but in your experience with the COVID positive patients, do you have a sense of how many present asymptomatically and remain asymptomatic? And how many have a rapidly progressive course that requires ICU care?
I don't want to monopolize. I'll let one of the clinicians answer first. I have an idea, but I think it's my real first comment is I think it's early on. But Bertha, Renee, or Liz, any comments?
Yes, I will say what I have seen in my team, many of the patients are asymptomatic, and a very small amount of the patients, let's say let's put an example so you can have an idea. I had 12 patients in one building that were positive. From those 12 patients, only 2 of them developed pneumonia and respiratory issues. The rest of them have been asymptomatic in the facility, being monitored. From those 2 that had pneumonia, then we treated them in the facility and they recuperated and they didn't go to the hospital. Now, in another building, we had 7 patients. One of them was sent to the hospital. Being in hospice, the family didn't want her to go to the hospital, but they sent the patient to the hospital. and the patient was in the hospital for 2 weeks, came back, still positive for COVID, and is now without COVID in the building. So I would say that a small part of the patients is the one that develop severe symptoms, and the majority or many of them still stable in the facility. So we had to monitor them closely. I think it is related also to the chronic conditions and the advanced age that the patient have that can cause that, and all of those things have to be taken in consideration. I have seen also cases that after 5 days, they develop symptoms of pneumonia in the facility. So that's why we are implementing chest x-rays and follow-ups labs periodically to see if one of those that have been asymptomatic will develop symptoms later in the process to catch it. I don't know if I answered, but I don't have the specific statistics on how much. But that's usually what I've seen.
I have a comment as well. One of the things that I've noticed is not very much respiratory issues. The things that we're noticing first and foremost is the agitation or altered mental status. In our population, they just don't look right. They don't look like themselves. We see these folks, you know, very frequently during the week, every day, every other day. And so we notice that small change that they just don't look like themselves. And that is one of the first things that I've been seeing is the altered mental status.
Yeah, the only thing I was going to add was that I think it's a great question, Dr. Alcindor. I think that when this is said and done, we've been documenting everything to the best of our ability in our electronic record, that we're going to go back. We've been tracking not just admissions, but also just transfers to the hospital and back if they have to do with COVID. So we're going to have a lot of data to look at, and hopefully on a future call down the road, we'll be able to come back or at least present it or send it out to the FMDA population, or give it to Dr. Sanders to send out, because we have quite a bit of data with having over 6,000, we were at one time almost 6,500 members in the state. We do have quite a few positive, unfortunately. So I think our number of patients should give us some idea of just how many are actually asymptomatic versus the different types of presentations, as both Bertha and Liz alluded to. Good question.
Dr. James, we had a comment from Leslie around fatality rate and the relative percentage of in the state of testing. Yep. So do you want to address that?
Sure. No, I agree exactly with the comment. And I think I alluded to it. Just we could go down a path on almost all of these. There's so much to talk about right now. But the fact is, I agree that the strike teams of the National Guard that have been going in have pulled back more covers or layers of the onion, or whatever you want to call it, to see that there are more people positive, there are more deaths in the home. And that's why I think it's gone from a couple of weeks ago from the 20% up to 40, 50% or higher. So I agree completely. And even though in my tribute to Dr. Fauci, I said I'm not a forecaster, what I've told my team and even people nationally in Optum is hold on to your hats, because this could get a lot worse before it gets better. I'm very killer to say I'm not political, I'm not an economist, but I just don't want to see the opening of anything adversely affect our population. I think most homes are holding fast to the very careful restrictions on visitors and trying to keep it down again to those that are in an end stage condition in the last few weeks of life or had a significant change in condition. But overall, I agree with the comment, and I think we're going to see more of it as we see more people tested and more reporting, not just the testing, but now the reporting is mandatory. That's a good comment.
So we had another question about any correlation being seen between the severity of COVID symptoms and the flu and pneumonia vaccine. And I address that to all four of you, if you guys have seen anything that suggests that.
Yeah.
I don't think we've looked at that. I mean, we do have a very high flu and pneumonia percentage of vaccination rates. So there could be a correlation based on what Bertha and Liz are saying about a lot of more asymptomatic patients or minimal symptoms. But I don't think we've paired that data yet.
Okay. There was another question about, are there any reports of agitation and altered mental status in the literature with COVID-19, as noted by Liz? I'll take that one. I have seen some case reports in reading through that has talked about the varied presentations in the older population and mentioned altered mental status and agitation. If anyone has a direct reference, I welcome you guys to either speak it, say it now, or share it in the chat.
Hi, it's Dr. Edwards. I can say that I had one patient that had stroke-like symptoms, went to the hospital, diagnosed with TIA, was tested negative for COVID, sent back to the facility. A few days later, started having seizures off and on, new onset seizures. Sent back to the hospital. We also tested again at that same time, and the hospital sent him back with a UTI. Our test then subsequently came back positive for COVID. So we then sent the patient to the hospital. Since it was a neurological type problem, I felt it was safer to have that patient in the hospital rather than treating in the facility. So I'm seeing very different types of presentations, from asymptomatic, nothing but a low-grade fever, to no fever at all that are testing positive, to your pneumonia patients. It just really varies.
Thank you, Dr. Edwards. Thank you for that. We had another question about has anyone incorporated remote tech patient monitoring as a tool to monitor a treated place? I'm assuming you mean maybe like the smart watches, or the ability to use the remote EKGs or those kind of things. I don't know, Anthony, Farina, if you want to clarify the question to the group.
Yeah, thank you. I was curious to see if you're using anything remote technology, like you'll see Massimo with those pulse oximeters, O2 saturation readers that allow for you to send that data remotely to a monitoring station, anything of that sorts.
I'll just answer, not that I'm aware of,
No.
and not that I'm aware of in any of the markets that we deal with in Optum. We're in 25 markets or so throughout the country. However, I'm aware of it. There's another part of United Healthcare that's been doing those in beta testing with some of the home patients. I mean, this is before COVID even came about. This is last year. That would have been great to have. And I think my answer summarizes that I think we'll see more of that in the future. And God forbid we have another pandemic. Hopefully we have things like that you're mentioning, so we can do that in the future for people and treating them in the nursing home or in their own homes, rather than having to send them to a hospital. Good point, good question.
Yeah. Yeah, and there's been some, what I've seen is there have been companies who do remote patient monitoring who have made suggestions that their equipment and their technology could benefit the providers who are trying to do the telehealth, especially where you don't have a real platform other than a FaceTime on your iPhone or WhatsApp. But I could say that just speaking on, what we're doing in United Healthcare is we are looking at all those digital pathways and opportunities to utilize tools. So I know that there are companies who are doing it. It's usually a very regionalized type of approach. is something that I think we are going to have to think about in the future, you know, as we're looking at how do we detect disease earlier. But I'm not seeing this utilized in assisted living facilities or nursing facilities at this time.
Diane, if I make one quick comment, I was trying to catch Kathy Lipton. Dr. Lipton is a fellow national medical director with Optum to myself, and she put in some links that might answer some of the questions above. I'll be looking at them, but they're obviously there for anybody to look at. I think there's 3 different links there that people could look at.
Yep, and I was going to mention that. Thank you, Dr. Lipton, for sharing that. We were able to capture that, and we're going to be able to put that into our COVID-19 library as well. I do thank you all for participating. I know we're over time. I thank you all for listening in, and you know, to Renee, Bertha, Elizabeth, Dr. James, I just thank you for everything that you guys shared with us on this call today. If you have any questions, please do not hesitate to reach out to me, and we can always redirect it back to the team if you have a direct question for them. I thank you, and I ask you guys to have a great and wonderful day.
Thank you for having us.
And everybody keep up the great work out there. Thank you. Thank you, Dr. Sanders, for hosting again.
Thank you.
Great job, the Optum team. Great job, guys.
Thank you.
Thank
High
you.
praise. Thank you, Dr. Kaplan. Thanks, everybody.